And welcome to our December's Bariatric Happy Hour. I'm your host, Faiz Shariff, and joining me is my awesome co-host, Dr. Juyeon Park. For those of you joining us for the first time, these webinars are held monthly on the fourth Thursday of each month, except this month because it's the holiday season. And during these sessions, we review seminal papers that have significantly influenced our field and alternate these with discussions on technical aspects of metabolic surgery. In addition to these webinars, the Bariatric Surgery Training Committee also hosts a monthly The Fellows Project, covering key topics from your core curriculum. These sessions count towards the didactic requirements needed to obtain the ASMBS Fellowship Completion Certificate. Our next meeting is on Jan 3rd, and the topic for that month is the surgery or medication to treat obesity. And our presenters are going to be Dr. Wilson and Dr. Martin. I have two important announcements. First one, please submit your questions for our fireside chat held during the Fellows Project in the month of February. So let's make this session a dynamic, engaging, and tailored towards a tailored experience for you, because depending on these questions, the content and discussions will be decided. So don't forget, submit your questions, and we can't wait to see your submissions then. And the other announcement I have for today is don't forget to submit your abstract for our annual meeting. I think the deadline is Jan 8th. I'm going to introduce our guest. It's a true honor to introduce our distinguished guest, Dr. Pearl Ma. Dr. Pearl Ma is a highly respected surgeon, dedicated researcher, and the Director of Research at Advanced Laparoscopic Surgical Associate, Community Health Partners at Fresno, California. Her contribution to the field extends beyond her clinical practice, as she plays a pivotal role at ASMBS. For anyone who's involved with ASMBS, knows Dr. Ma. She currently serves as the president of California and Nevada chapter and is a board member at the ASMBS. Dr. Ma's passion for education and mentorship is evident in her role as the program director for her Advanced GI and MIS Bariatric Fellowship. And we are privileged to have her share her expertise and insights with us today. So please join me in warmly welcoming Dr. Pearl Ma. Thank you for joining us, Dr. Ma. I will now hand over to my co-host, Dr. Juyeon Park, to introduce our next guest.
All right, our fellow presenter today is Dr. Donovan Hui. I actually know him from middle school and all the way on, but he went to University of Virginia for his bachelor's degree in psychology. He got a master's afterwards from Rosalind Franklin University of Medicine and Science in Chicago. And then afterwards, he went to medical school at the same place. And then he did his residency at New York Medical College, Metropolitan Hospital Center in New York. And then finally, he is back at University of Virginia to do his fellowship in MIS Bariatrics. So thanks, Dr. Hui.
Am I sharing my screen? No, I'm not. Probably not. Okay. Good evening, everyone. So I'm going to be talking a little bit about reversal of gastric bypass, indications and surgical techniques. Thank you, and everyone from ASMBS for letting me speak a little bit about this. It's actually a very interesting topic, and although the literature was not overly robust, it was a very interesting topic, and I think the conversation and discussion we're going to have from this is going to be very fun. So just briefly, this was published from ASMBS in 2022, looking at the rate of gastric bypass in all bariatric surgeries, and you can see a consistent rate of gastric bypasses performed year over year. But not everyone should get a gastric bypass or can tolerate the bypass anatomy. So here I have a retrospective analysis, or not a meta-analysis of published in SWORD in 2016, includes 35 studies published between 1986 to 2015. And it's a total of 100 patients, including these 35 studies. And just a brief summary is that the most common indication for reversal of the bypass was malnutrition, and the techniques are often were the hand sewn technique, linear stapler or the end-to-end stapler, as well as a few studies published on endoscopic techniques for reversal. So this is kind of like a summary slide of the included studies in the 35 studies. Note that more than half the studies were published in 2013, and the sample size per study is a little bit limited, although they were able to compile about 100 patients in this meta-analysis. The time for reversal ranged pretty broadly from 3.5 months to 298 months to the time of reversal. And the primary reasons for reversal of bypass is kind of all over the board, but if you kind of look more closely, malnutrition related causes were in the predominant cause for reversal. And that would be malnutrition overall, excess weight loss, protein malnutrition, micronutrient deficiency, dehydration, vitamin deficiency. And then there's other symptomatologies that led to reversal, such as dumping syndrome, postprandial hypoglycemia, insulinemic hypoglycemia, ulcers, and persistent pain, nausea, vomiting. So how do they do the reversal from the bypass anatomy to the reanastomosis of the GG? Of these techniques published in the meta-analysis, laparoscopic procedures were the predominant form of reversal. About 19 of the cases were performed open and 3 were done endoscopically. The techniques for the gastric gastrostomy was reported in only about 42 of these patients, so they're not well published in the literature from that meta-analysis. And from that, a large majority of them were hand-sewn gastrostomy technique was performed, although linear stapler and end-to-end staplers were used also. And then the consideration for the root limb was also reported in about 56 of these 100 patients, in which 57% reported they did a reanastomosis, and 43% of them reported they did resection of the root limb. And the majority of the time, it was published that the reanastomosis of the root limb was in the setting of malnutrition. So they preserved that root limb in malnutrition patients. And then the outcome, as expected from these patients, there would most common outcome was weight regain, which was probably intended because in the setting that patients were having malnutrition from their bypass. And then although they were able to reverse the bypass anatomy, some patients reported persistent symptoms despite the reversal, with persistent pain and low BMI without ability to regain weight after their their onset of malnutrition. So that's the basics of that particular paper. And then I did a brief review. It's just really one slide about from Scott Shikora's paper published in 2016 as well. It was 19 patients from 2008, 2015, describing indications, techniques, and outcomes for their reversal surgery. Indications for them were malnutrition, excess weight loss, chronic nausea, vomiting, pain, neuroglycopenia, internal hernia complications, and the need for gastric endoscopy. And the technique for them was linear stapler for the reversal using for their gastric gastrostomy. And then again, here we mentioned is the limb preservation was individualized based on indication, which is for malnutrition for the majority of these patients. And then this is just a brief summary table of their patients, but not a whole lot of new information there. And then the conclusion basically was saying that it's very feasible to do laparoscopic reversal for these patients. 15 of their 19 were able to do laparoscopically. It is technically challenging, but they were able to do that with complications related to the reversal, related to outlet stenosis, obstruction, requiring additional interventions, and then patients had some chronic diarrhea or unable to wean from TPN from their malnutrition. So those are 2 studies I looked at, and for me, I was looking at and thinking about the considerations for reversal surgery as other interventions prior to proceeding with reversal. Response to patients with a gastrostomy tube placement, if you can get the nutrition through their remnant limb, measuring the common channel length, and then additional interventions at time of reversal, such as partial gastrectomies that are still having obesity-related issues, not related to malnutrition, if a pleuroplasty is indicated, or in some instances, a pancreatectomy was indicated.
Dr. Ma, do you want to share your knowledge?
Sounds good. Thank you, guys. Thanks for the nice intro as well. Thanks, Donovan, for that nice review. Thanks, Dr. Park, as well, for the introduction and the invitation to talk today. I will share my screen here. Let's go back to the beginning here. Okay, so reversal of gastric bypass. This is a great topic. Can you see everything okay? I think so. Yeah, okay. These are my financial disclosures here. And I'll go over a little bit more to expand on the indications and some of the technical aspects and some unusual cases. So first of all, reversal of a gastric bypass, I would say, is a challenging revisional operation. It's not just a technically challenging operation, but it's also the decision-making that leads to needing a reversal of the gastric bypass, right? You've worked up these patients, you've put them through 6 months to a year, 2 years of nutrition, and they're finally here, they get their gastric bypass, and either immediately they have issues or long-term they have issues, or something happens in their life and something happens and they need someone to manage that. So really it's a multidisciplinary decision. Not a lot of patients get reversal of gastric bypass, but we always talk about, right, that in the consent, right? Why would you do a bypass versus a sleeve? Oh, a bypass, you can reverse it if you ever need to, but actually needing to do so is such a low percentage. So you really have to understand kind of the complications of a gastric bypass. And I think that you have to be able to manage those complications. So when you get out there for the fellows and you're in the real world, if you are doing these operations, gastric bypass, SABs, OAGBs, et cetera, you have to be able to manage the complications, first of all, right? It's not a sleeve them and leave them type operation. So you have to be able to reverse and take care of those issues, and especially even with the gastric bypass or even reversing a SABI, if you want to start doing those. So just keep that in mind. Whatever you do, you have to know how to take the responsibility and manage that. And so I just wanted to review my paper that we published in 2019. It was just kind of the largest kind of single center, and meta-analyses and things like that are great, but sometimes it's just such a small group of patients. And we really looked at our patient population to see what was going on. So we did a retrospective review of 48 patients who underwent reversal, from 2012 to 2016. And to give you an example, this is like 0.1% of all operations. So during that same time frame, we did over 2,100 gastric bypass procedures, and then like over 500 revisions of bypasses. So to kind of look at reversal, that's such a small percentage of people. And when we looked at the indications for reversal, a lot of it was marginal ulcers. About half of those patients had chronic recalcitrant marginal ulcer. And I'm not talking about, oh, they had tobacco and then they had an ulcer and then we reversed them. It wasn't like that. It was these ulcers that either they couldn't stop smoking, they had some other issues. Half of those, you can see a lot of these patients here, half of our group overall had some malnutrition issues too, along with that. And so sometimes that goes with marginal ulcers, right? People have trouble eating. You put on a TPN, you try to optimize them, of course, before the operation of reversing them, because you want them to heal, of course. With our marginal ulcer population, we found that almost 70% of those patients also had concurrent substance abuse issues, including tobacco abuse, but also alcohol and other substances. So that was something that was also pushing us towards reversal instead of kind of doing revision of their gastroenteritis for their marginal ulcer or some type of vagotomy and things. So there are other compounding factors that led us to make that decision with them. Chronic pain and nausea was a very small percentage as well, and that was kind of a interesting subset of patients. We had 3 patients that we actually reversed to normal anatomy within 6 months of their bypass. And so sometimes when you operate on patients, some things kind of get, some people have buyer's remorse, or they just have these, multiple readmissions, endoscopies, explorations, and things, and we didn't find anything an anatomical cause why they had pain. And then once we reversed them, we realized there was psychological, either pain, seeking type of behaviors that were evident before, but really came to the forefront later on. So it was almost like we called it a psychological intolerance to kind of be able to deal with that. And also a subset of patients that have reactive hypoglycemia or postprandial, the hyperinsulinemia issue too, where they have a CGM, or they're on medication, acarbose. We've maximized the medications. They've seen an endocrinologist, and they're afraid of sleeping at night because their sugars will drop, or they've passed out multiple times because their sugars will drop after eating. And they're on optimized diets. Sometimes with these patients, we bring them in the hospital, we admit them, we watch their sugar, put them on a diet, and they still have issues. And so those patients, we talk about reversing it and go from there. So I don't know if you can see the 30-day complications. I should probably move that somewhere. So the 30-day complications, looking at that, we had a pretty high complication rate. And I say this not because we were just crappy surgeons, but really the nature of the disease. So especially the marginal ulcers, right? It's a chronically inflamed area. There's something that's driving that inflammation. So these operations are a little bit harder. It's not a clean field, especially if they've had perforations or prior revisions of their gastric J. So the blood supply is compromised a bit. So our anastomotic leak rate, yeah, it was about 10%. So it's kind of high. Our complication rate was 29%, kind of high, And so we did have these issues happened, but mostly, again, because of the chronic marginal ulcer issues too. So we did have some mortalities after 3 years or so. We had one 30-day mortality, and that was because of a heart attack or a PE. And a 3-year mortality, one patient had severe alcoholism and had complications due to that, even after the reversal. And we had one patient that had also asphyxiated on a hot dog too. So, okay, you guys, I'm going to do a lecture. Sorry, my kids are here excited. And
Hi.
Hi.
Hey, this is the holiday season, so they can come and say hello.
Okay. Okay.
Hi.
You gotta be quiet though, okay? Can you guys be quiet? I'll open it later. Okay. Yeah, early Christmas. Okay. So let's get through this presentation quicker. I love you guys. I know. Okay. So we published a little bit about overview of gastric bypass procedures. We presented this, I think, a year ago too, and from Mayo they did a compilation of different operations of how you reverse a gastric bypass. And so there's different ways of being able to do this, and I'm going to show some videos of that, of how we reverse that. So this was courtesy of Farah Hussein, University of Arizona, as well as Oregon, OHSU. And so here she's dissecting off the roux limb, taking that off JJ, and completely resects it. So you can see it's ischemic. It's a retrocolic anatomy. So she's pulling that up robotically, and you can see it's ischemic. So she's planning to resect that completely. So she kind of started from the bottom in terms of taking off that roux limb there. And so you can resect it, as Donovan mentioned, or you can preserve it. Some people use it as a jejunostomy feeding tube. You can leave that in place, or you can also re-anastomose, especially malnutrition. Definitely, you don't want to take off like a meter of small bowel. It feels kind of odd to do that when you're doing malnutrition, right? So she's basically making a side-to-side gastrogastrotomy, and there's a lot of variation in terms of how people do their anastomoses here. And so kind of interesting. This is a side-to-side with the fundus up there. She's closing it with the V-lock, single layer of that here. Shut the door again. Okay. So you can see it's you could do this in a single layer robotically. And she does a leak test with that. And so the fundus is still preserved up there. And so everything looks good. She does endoscopy, goes down. So this is one example you can see of just restoring the continuity of her anatomy afterwards. And so she does a little bit in the cyan and green. Everything looks great and beautiful here. So another example here, courtesy of Dr. Mohammed in Orlando Health. And so he shared with me his video. And you can see sometimes with the gastric bypass anatomy, right? They could have had an open operation. They could have had anticolic, antigastric, retrocolic, it's just the variations are so variable in terms of what you get. And especially if you're revising someone else's bypass, the pouch could be of various sizes. It could be very short. You could have a very short stuff. So there's a lot of different ways you have to adapt necessarily to this patient. So this patient's actually undergoing a reversal to for
Sadie,
weight
looks like, yeah.
recurrence. Yeah. And so they're going for a Sadie eventually in the same time, in the same operation. So here you can see that pouch is huge. And so he's re-sleeving that pouch up, or he's taking off that aspect. And it's a nice long pouch, which is actually really nice in a reversal operation to have that nice long pouch.
Yeah.
And so he did a single layer back layer first. He's already resected off the fundus of the gastric remnant. And you see that assistant's holding, or his arm is holding that up on that end. And so he does this in 2 layers. Sorry for the choppiness. Hope that goes away. But he does a really nice anastomosis over the bougie, opens it up, does it in 2 layers here. And then later on, he resects that remnant fundus. So it looks like kind of like end to side. And so you want to kind of mimic the sleeve anatomy when doing this. And so he does a nice job with that too. And then he puts the bowel back into continuity, does a side-to-side anastomosis for that as well. All right, so move on to the next one here.
Particular size that
Sorry.
you're aiming for when you're trying to make these, like when you're using a linear stapler, you would use the whole 60 centimeters or as much as the pouch will give you? I'm
For
talking
the side-to-side up top, yeah,
Yeah.
normally they do a 60 for that. Yeah.
And if you're doing
And
a
you can imagine the
handstand-
food kind of goes to the side, right? And then it kind of goes down a little bit versus kind of straight down. So it's kind of an interesting lumen that develops. Dr. Elchar also does one. He kind of does it more on the greater curve side as well. And so I'll play his video too. So it's just interesting. People kind of do it in different manners.
Yeah.
But it kind of depends on what you're trying to accomplish. So if you're trying to reverse this because one of the downsides of reversing, right, is weight recurrence. And so a lot of patients regain a lot of weight. And so one thing you can do is doing a modified sleeve. And I have a slide for that later, but Himpins initially described this in 2013, talking about modified sleeve in that sense. And so you reverse it and then you trim up the fundus. And so that helps hopefully preserve some of the weight loss too afterwards, and not the weight recurrence as much. But if you're doing this for weight, then I'm trying to make it similar to a sleeve configuration. And so most of us, when they're doing that, will try to kind of do an end to side anastomosis. So he's taking it down. Here you can take the short gastrics around. Let's speed up a little bit here. So this is anastomosis. He uses he said 2.0 Vicryl, and then it does a VLOC for his fellows. And here he does a kind of a smaller anastomosis, you can see.
Yeah. Oh, that is very small.
Yeah. Well, it seems to work well. He passes the tube down and is able to go down. But this is kind of the final product. So more on the greater curve side, more on the lesser curve side. And he sleeves it up a bit more.
Oh, I see what you, okay.
So in that sense, it does look like a nice arc on the outer side here. So there's a nice tight anastomosis, and then there's a imbrication at the staple line there too. So just some technical issues. So side-to-side anastomosis again that they do, putting things back into continuity as well. So, okay, so another way to reverse this I found, it was kind of interesting. This is from Egypt, Dr. Heaney, talking about using the rulin almost as kind of interposition. And so I thought this was interesting. So they created a small rulin, like they shortened the rulin and then left it kind of blind limb there. And then put it into, this patient had a prior sleeve, and so went to a sleeve to a bypass and into that stump of the gastric pouch, right? So there's a short rulin that goes into it. So when you eat food, it goes down, but theoretically goes into the system. Although I don't know about marginal ulcers yet on this, so that's a little interesting.
I know.
Yeah, so
On both sides.
it's interesting. You know, you avoid the lower aspect, I guess. You know, you could just keep everything in the upper quadrant. Doing this. So this is a slide showing the Himpins, the modified technique for the modified sleeve. And so This is kind of the principle of keeping a lesser curve base, kind of end to side, and then taking off the fundus and such too. So any questions there before I kind of go into some of my cases that are unusual?
Dr. Park, do you have any? I mean, I have a bunch of questions, but we can
No,
go
let's
through.
just do these first and then go through all
Yeah.
Okay.
the questions.
Okay, sounds good. All right. So this was one that I had. She was 69, did really well with the gastric bypass. And in the last few years, she was admitted multiple times. She went in for exploration. She had a reduction of intussusception. And then later on, she came back in with, again, intussusception. And the surgeon at the time revised her JJ, did 2 separate anastomoses, kind of chopped the whole JJ and then did a reconnection. And then came back in again with another intussusception. And so it was interesting looking at the videos and everything because it was actually at the common channel. And then she had bleeding marginal ulcers and then pain and blood. It was just like, she was just like, come on. Like, I'm done. I'm 69. I'm done with this. Can we talk about reversing this? And Semper had a series out of Utah talking about, reversing poor intussusception and chronic intussusception because you have those migratory pacemaker cells that develop. And so what do you do? This is kind of an unusual case. So I worked her up. There was something lead point that's causing her to have intussusception. Did an enteroscopy, capsule endoscopy, looking in. Everything looked fine. There wasn't a gastric fistula that caused her marginal ulcers as well. Underwent, PPI use, had a chronic marginal ulcer, and just discussed her case. And she was like, I'm really done with this, and I'd rather have my gastric bypass reversed. Like, let's just do this. So this is a CT scan of when she had one of her intussusceptions and had a exploration for that. And so we're reducing this because it's actually, when you see this, it's actually at the common channel. So it's not, normally intussusception's at the JJ, right? It's going into the JJ, a big channel, but this was actually probably about 30 centimeters downstream from that. So it was a little odd.
Interesting.
So so it's like, how do you prevent this? There's, palpating and trying to see if there's anything intraluminals or food bezoar or something else, but nothing. And so, how do you tell the patient it might happen again or it might not happen again, right? So we agreed on reversal, and it's nice sometimes because they're thin, and so technically it's a little bit less challenging. And so my partner had done the bypass, so I kind of knew what to expect. I liked starting up top right away, and because the GG is kind of the aspect that really needs to be done well, and so I kind of focused my efforts up there first. So I always kind of resect the root limb first, and that way you have a handle. And I like to see the blood supply of the stomach and make sure that it's looking nice. I know what I'm dealing with in my pouch. And then creating that gastric anastomosis here. And so you can do it in single layer, you can do it in 2 layer. I've realized over time that doing it in 2 layers is a little bit nicer for the blood supply and such too. And so we do a hand sewn. I don't do robotics yet. And so we hand sew that together. And usually over at least 34 French bougie at minimum, like, right? This don't necessarily need it super tight. And then for her, because of her weight history, I do take off that fundus part and make sure that everything's kind of clean in that aspect. So because of her anatomy also, so she was retrocolic, took that down. And then her JJ, you can see, is pretty kind of like chronic. Maybe there was intussusception in the past there too. It wasn't pretty, right? This is just like very patulous. So I decided to resect off that JJ completely and then put her back into continuity and just make sure that everything looked in line. So the biggest thing is when you go back into these patients, right? If your general surgeon goes in and they're looking at the anatomy, are they going to be confused? Like, what the heck happened in here? There's so many small bowel anastomoses. And so what we want to do is just kind of make it as natural as it was before, right? And so for her, we put everything back into continuity. I do an end-to-end hand-sewn anastomosis. And so that way there's no question of or any concern of what the anatomy is supposed to be like. And so it looks like everything's supposed to be right in line. And so making sure that you correctly put each limb back to where it's supposed to be. And so we do a hand-sewn end-to-end anastomosis, close up the mesenteric defect, and then just kind of following it through, making sure that you have everything in line. So that was one case that I did. She's doing pretty good actually. And I talked to her about the weight
So
recurrence
no
that
more
might happen. She
interception?
no more interception. No more interception. That's crazy.
How
Yeah,
long?
right.
Wow. How long back was that? Like, when did you do this? What's the follow-up like for that
Probably like,
patient?
oh, 3 years or
Oh,
so.
wow.
Yeah. And I still see her. Yeah, I still see her. And so even after reversal, mom was cautious because the complications they can have is also reflux, right? If you've
Yeah.
gotten into the vagus nerve and you have gastroparesis, so they can still have issues afterwards. But her weight gain was about 30 pounds or so afterwards. And then, so she's keeping an eye on that too. So this is her case there. I did this case I did about a couple months ago. So patient came in and he had his sleeve, horrible reflux, grade C esophagitis. You're like, okay, I'm gonna just do a bypass, have a hernia repair. And afterwards, he was, he did great with just overall weight loss in general, but he really had low blood sugars and he was on acarbose. He hated the acarbose because it made him nauseous. His endocrinologist put on Ozempic and tried to stabilize his sugars, which is actually helpful in some patients also if they can get on a GLP-1. His workup was all negative and just his sugars would drop into the 30s and his quality of life was just horrible. He was just like, I'd rather deal with reflux again than this. He was napping, he was just kind of just fatigued, just wasn't living his life. So I was like, okay, I will reverse this. I talked to my old team. We're like, okay, we will do this. Your reflux is going to come back because like I can deal with that. And so I was like, okay. So because when I do a gastric bypass, I make a small pouch already. I was like, all right, fine. I knew it was
Yeah.
going to be a little bit annoying. And so my pouch is pretty small. And so I take it off early so I can demarcate. I'm using some indocyanine green here to look at my blood supply. And you can see it's kind of small, but it's okay. And then actually for the gastric remnant, because we had chopped off and it's kind of like in a weird shape right afterwards a little bit, it kept flopping onto itself too. And so I had to be very careful about the orientation of this. And because it's a little bit, the posterior attachments were less, so I had to pexy it a little bit too to make sure it didn't twist and turn too. And so this one I did a 2-layer anastomosis. I always scope the patients afterwards, making sure that everything looks good. And so that one was good. And so sometimes you can leave drains if you want, as you get more comfortable. I think early on when you start with cases, I always left drains. And then as I got more confident and did more cases, then I stopped leaving drains afterwards. Anyway, so this is another case for that. And we scoped. Otherwise, he's doing okay. We're still at less than 2 months out, so we'll see how he does. Anyway, so after reversal, as we mentioned, these are some of the complications. Sometimes with that root limb, leaving it in place, I've seen bowel obstructions from that too, or some people say have bacterial overgrowth or chronic pain. We've used to, if in the cases we've left the root limb, we've tacked it up to the anterior wall, we've put clips all the way around, so that way if you ever needed it as a J2, IR could just go in and find it and just that way saved you an operation. So that was one technique that I learned too, is that you could just anchor it up, put clips around it so you can identify it, and then place a feeding tube there by interventional radiologist if you ever need to.
That's a
And
neat
so
idea.
one thing I was just going to end here is, so I'm on this gastric bypass Facebook group and a reversal of gastric bypass. And I don't know how they let me in, but I can't respond to some of these things, but there's a lot of folks out there that need a lot of help. And it's interesting, they'll be in their hospital gown, kind of texting or just asking for advice and things. So it's kind of funny. This one was like, hey, I need a reversal doctor. And this is what they came up with. I was like, who does reversal, doctor? Do you recommend any of these doctors? And so I texted Dr. Shrive and I was like, hey, by the way, you're number one that does bypass reversals. So what I've learned from this talk is that if you guys need someone that does a reversal, she's not necessarily happy about this, but this is her info. If you ever need, she's at OHSU. So that's one thing. Anyway, that's my talk. Hope I didn't go too long, but happy holidays to everybody. But I welcome any of your questions. I know it's a lot. These are tough patients sometimes. A lot of things come up, but it's really and it's disheartening when you take apart a gastric bypass that you created, and it feels a little unnatural each time to do it. It feels a little bit like it hurts a little bit, but the patients do well, but I think you still have to follow them and such.
Thank you. That was a very, very interesting topic. And, the way you presented that was awesome. I need to review that paper that you published. I think that's a gold mine there. Now, anyone else has questions? Because I can start asking, and then when I start talking,
Looks like there's one question in the
is
chat.
there a question in the chat box?
Do you have a baseline serum ghrelin level, and do you reach a ghrelin level for those patients you're going to?
Do I check ghrelin levels?
Yeah. Do you ever check?
Not,
Like that's a.
I never, actually, I don't even know how to order that outside of a lab. Like, I mean, in terms of like a clinical basic science lab, it's not something you can order on Quest easily. So I'm in the community practice, so I don't have access to that to be able to do that. But
Neither do I.
But then what would you do with the elevated ghrelin or low ghrelin? It's one of the factors, and especially depending on what you're reversing the patient for.
I actually have a question for like preoperative planning, because a lot of these patients aren't going to be emergent in the hospital. It's going to be more like outpatient basis, right? Do you get certain imaging? Like, do you have to do like a upper GI or something like that you want to see before you do a reversal, or do you just know that?
That's a great question. Yeah, I think it depends I think it depends on if it's coming from somewhere else, right? And you have no op reports, you don't know who the surgeon is. If it's not local in your area, to do revisions and know what the anatomy is going to look like. Ultimately, it's just kind of finding the anatomy while you're inside. And so upper GI, if they do have marginal ulcers, right, looking for that gastric fistula causes or etiology, they probably had a lot of workup already. But if they're reversing for something else, then let's say, because if they had chronic abdominal pain, they've had CTs, they've had upper GI, they've had endoscopies. And so I think it depends on the indication for the surgery more than anything. For weight recurrence, same thing. You've had an upper GI for a lot of these patients, but I want to see there's gastric fistula causing the weight gain too, as well. So I've been reversing more bypasses, I think, for weight, and actually going to a SADI or a DS, single stage or two stage, more recently.
Interesting. Now, for some of our patients, more, like you said, the most common indication either is because they have marginal ulcers, like your paper showed, and they have marginal ulcers and malnutrition. So what is your algorithm? What do you first do? Do you offer them a GJ revision? At what point do you say, let's go for reversal, or are you going to put a G-tube? Sometimes I feel like I mean, actually, I'm dealing with a patient who has this non-healing marginal ulcers and, no risk factors, nothing. And her nutrition is like really poor. So what do you do? Would you put a G-tube first? Let's see if that marginal ulcer heals, then offer GJ revision, and then go for reversal? Or what kind of an algorithm do you have for that? Those specific patient population?
Question. So chronic marginal ulcers with malnutrition, with no etiology. What size is the pouch? Gastric pouch? Is it a long pouch? Normal?
It's 5 centimeters. I mean, I did the pouch, so it's like 5 centimeters and over a 40 French bougie.
Okay. And the other factors that come into play, the other stuff, right? Is she handling the bypass well? Is there alcohol addictions or something else that's going on that, vitamin non-compliance, the stuff that the responsibility of the bypass, is that a factor at all? Or weight?
So, no, she takes her vitamins, but then because of the marginal ulcers, her nutrition is like she barely can tolerate her, her
And then
food.
does she have a lot of diabetes and things like that before this surgery, stuff like that? Okay. So, I kind of take all those things into account, because when you reverse it, their weight's going to come back, their diabetes come back. And, I got to be honest that we've had some patients where we've reversed them and we brought them back to the bypass or something later on in life. So, I've had patients that have had every operation before. And so, So in these patients, I think it depends. For nutrition wise, we'll put on TPN.
Oh, you
The
go for
idea of a
TPN.
feeding tube is always daunting, especially in these patients, right? And then if I have to reverse it, I don't know, the G tube's there. It's like I don't want to disrupt the remnant if I don't have to. But if they have malnutrition, I can just put them on TPN for a little while, get them kind of bumped up in that sense. If it's the first time they've had a marginal ulcer and are, same thing, right? Treat them with PPIs, BID, Carafate, see how they do, rescope them. You still have a marginal ulcer, and now you have stricture and stuff like that. Then it's like, okay, it's getting worse. And so then you want to think about, okay, do you want to revise this to a smaller pouch, a near EJ? So there was a thought of no ulcer, no acid, no ulcer. I know I've had this discussion with Dino. He's seen ulcer after EJs and things.
Yes.
We have not, and I've had quite a big series of folks,
With
and
EJs.
we have not seen recurrent ulcers after EJs. But I don't know if it's because we hand sew it, all of ours, versus the kind of stricturing that sometimes happens with circular staples. And so that's one thing but they do have some issues afterwards. Sometimes that, they can have some dysphagia issues, esophageal dysmotilities that develop after EJ. So I get that some people are kind of shying away from the EJ, but that's kind of our algorithm is to either, if we want to preserve their weight, to decrease their risk of comorbidities coming back, then we'll convert them to a near EJ or EJ. Sometimes having that little gastric cuff is nice for healing. We've noticed when we did our gastric bypass revisions, our leak rate was about 18%. So pretty high. And it was because, but if we left a little bit of that, like half a centimeter of gastric cuff, then actually it just healed a little bit better, definitely. You can do the whole truncal vagotomy, also things like that too. And so some people had good success. I'm of the thought of you can try one thing, doesn't work, you can always go back in if you need to. I don't think you burn too many bridges, but if she is like miserable and too malnourished that you're like, wow, like I'm really worried about vitamin absorption, and or if you're worried about her ability to handle the bypass, or him or her, sometimes the alcoholism, as I mentioned, the person that died after we reversed asphyxiation with hot dogs, so that does happen. Like those issues still persist afterwards. So that's going to be a tough one, but yeah, but not everybody likes doing EJs too. I can tell you, there's people that are definitely team EJ versus team reversal.
You're talking about the surgeons, or you're talking
surgeons?
about,
yeah. And so this is where the
it
science
does
goes
worry
versus
me.
expert opinion, right?
Yeah. I mean, I do believe that what you said about just having a little bit of gastric tissue, I just feel that the sutures hold so much better when you have a little bit of more, like the small pouch. If you can conserve or preserve a little bit of stomach, that's better. I feel like the anastomosis holds better. But obviously, I don't have as much experience as you have in this field. Now, is there a particular number that you aim for before you go for this procedure in terms of nutrition? Like, do you check the pre-albumin, albumin, the vitamins before, or you're like, okay, this is the best we are going to get, and then let's go?
Yeah, I know albumin is not necessarily the greatest, right? But I do check those numbers, and I look at the weight gain more than anything, and making sure it's not just lower extremity edema, but making sure that their weight stabilizes and the weight gain is going up in the right direction more than anything. So it definitely is like, when do you pull the trigger? I think it's a judgment call more than anything, than a hard and fast rule. What about you guys? What about you, Dr. Park?
I mean, we do check those numbers. I will honestly say I've not reversed anybody yet, so.
Or how do you gauge like nutrition in terms of saying that someone is not malnourished anymore, in that sense, when you have somebody on TPN?
Yeah, for us, we're just checking albumin and pre-albumin. Unfortunately, that's just the way that our process is. Do you do anything different, Faiz?
No, I do make sure I check all the vitamins, and definitely pre-albumin and is what we rely on mostly here. Dr. Wei, do you have any questions?
So I have a very specific question because it's related to one of my patients. So I've done maybe two reversals so far, and one of them was horrendous. It's a patient who was 2 years out from bypass surgery, disappears to follow up, apparently went back to smoking, had a lot of abdominal pain, treated that with ibuprofen, and then comes in with a perforated marginal ulcer and about 1.5 liters of blood in her gastric remnant from a GG fistula, and had a splenic artery fistulizing to the gastric remnant, and they coiled that, and we resected the root, we reversed her, and then she comes back bleeding, and the most recent endoscopy shows the coil from the splenic artery kind of eroding into the mucosa of the stomach. What are your thoughts there? We're about 2 months out from the initial surgery, and it was a really bad surgery from the get-go, and we're just trying to bridge her so we can probably do like some sort of esophageal jejunostomy or something. I don't know. We're not excited about doing another operation in her, but that's currently where she's at.
The coil from the splenic artery embolizations eroding into her stomach.
Yeah.
That's interesting.
Interesting. I mean, how many layers of stomach do you go through?
Why would that? Yeah. Yeah.
Yeah.
Well, I guess depends where in the stomach is it eroding into. Because I mean, the issue is the coil, right? Not the.
I don't really know where I think it's related to somewhere related to the GG fistula and that region near the pouch, but it's kind of a weird spot, and I'm not really sure. It was she got scoped like 3 times. She bled like 3 times that readmitted, and they finally found this eroding coil from the into like probably the remnant stomach, actually, like pretty high up in the remnant stomach. But
I guess it depends where it's eroding into the stomach now, whether you can sleeve that off, and then you're gonna have to do something with that splenic artery thingamabob, potentially splenectomy even, and staple off that wherever it's coiled. I mean, it's probably coiled really distally, and so hopefully it would just be near the fundus.
Yeah,
proximal coil. Okay, yeah. Oh, okay.
That's a very unusual presentation. I mean, either way, you will be ending up with a splenectomy if you have to do anything. And I don't know. It's like the coils are not that big, so I'm finding it a little difficult to understand how the coil is going to kind of.
I think she eroded first and fistulized to the splenic artery, which is why she bled in the first place.
And those coils then get.
Where I don't know. So very, very odd, very specific question. I don't think there's a good answer besides making sure she's okay for now until we can get her to another surgery in a few months.
Was the revision done open?
Yeah, because she had perforation. So
yeah, you need time.
I have a question.
Hopefully she doesn't bleed.
This now, like when would you consider having to do open versus like a laparoscopic or robotic revision reversal? Are you always going to be trying to do lap and robo?
Oh, sorry. What? To ask when to do open?
Yeah, when would you be pushed to do open for yourself? Almost never.
Man, that's a tough. Yeah, I mean, yeah.
Your visualization, I feel like, is much better if you're staying laparoscopic or robotic. Like literally, if you can get into the abdomen safely, there are very few times. I mean, I don't want to say, you don't have to convert to open, but I just feel like the visualization, getting into the hiatus, working that space is so much better, minimally invasively.
I mean, we've had cases where you have bypass, right? And you have to do a bypass for a patient and adhesions, right? And you've had to open because of whatever, and then you take down the adhesions and things like that. Most of us will close the abdomen and then go laparoscopic to do the upper part.
Really?
So, because it's just easier.
Yeah.
Like I know we're already open, but to do the upper part, I've done open. So the only time I take everything back here now. So the only time I did open reversal was when a patient came into a neighbor hospital and they had a massive internal hernia. So they had to resect a lot of her small bowel.
That's
And so
different.
she was already open at Thera. And so they were going to have to reconnect everything. And so the surgeon actually called me and was like, hey, I can connect everything, but she's going to have a really short gut. And I was like, yeah, we should probably reverse her. And so she was, intubated, still on pressors. I was like, okay. So I came in and basically did the open reversal and such. And so that was an interesting case. So I put her back into continuity. She only had about 100 centimeters of small bowel left for that.
That's awesome.
So that was one open case.
We have some questions in the chat. The first one is, any downside to putting a J tube in the rulum after discharging it from the pouch? I feel like with a high leak rate, less anastomosis are better and having a good enteral nutrition option, or is that an overkill?
So yeah, as we mentioned before, so doing the J tube is fine into the rulum and keeping it anchored up, and that's definitely fine to do. We had a bowel obstruction in the past. I would say a couple of cases that were interesting because actually the small bowel twisted around that rulum and caused the internal
Interesting.
hernia. Yeah,
That
so
is
that
very
was interesting
interesting. Yeah.
too. I was like, oh wow, that was kind of cool. The leak rates, I think, there is that potential, and that's the risk of operation. And that's why the leak rates I was talking about before with our paper and such were more the GG. So the GG anastomosis is more your risky area. And I think that's why people like doing the side to side. I do know that every time I do a hand sewn end to end, I potentially have an increased risk of narrowing, leaks, and all that stuff. But I feel like it's a better, and I've done enough of those hand sewn that I know I can, what it takes to kind of for that to heal and such too. But it is a risk that you have to take. Yeah, it's not. Yeah, it's really your comfort. I know only some surgeons that do reversal. We had this discussion on Facebook. Was they always resect the rulum no matter what? They're like, people do fine. It's not a big deal. It just feels weird to take out a meter or more of small bowel, and
Yeah.
like when you don't have to, right? You're just like taking it out, and you're just like it's like a ribbon, and it just feels a little weird. I mean, for me, it's just like it feels unnatural. So yes, putting the J tube in the rulum for sure is definitely a option for you.
But do you worry about bacterial overgrowth, or like if suppose we don't use, so you put this J tube, fantastic J tube, and then the patient does well, and you now don't need to use a J tube, and now you have this rulum, 150 centimeters of this rulum just hanging in there, no flow, nothing going through. So do you worry about that, or am I overthinking?
No, it's always a potential, right? Like the whole roostasis syndrome. There's always a name for something else, right? That is truly a roostasis syndrome.
There's
But
always something.
there's always a name for something, right? Even IBS, right? It's just so if you ever need to, yeah, you could go back in and resect it if you need to, or do something. I know I sound kind of cavalier, but really, when you do your operation, how your technique is. Going back in it's not a one and done, right? Sometimes these people need different operations, and so even revisional operations, when you start doing there's not a one and done operation sometimes for people, and
Right.
so that's why going from a root to a sleeve to a sadie to backwards, like things like that, you got to have an open mind on that part, and also know how to manage the complications and
100%.
give those options to patients too.
And I think it's for fellows, I just want to put it out there, like, when you're practicing, you feel like, you want to give them the surgery. And at least that was how I was the first few years of my practice, that one perfect surgery, that's it. Because again, it speaks to the weight stigma. So they feel like when you're getting a bariatric surgery, this is going to fix all your problems. So setting the expectation is important. And I kind of find using this analogy, like I compare obesity to cancer, a slow-growing cancer. I said, like, sometimes one treatment for cancer is enough. Sometimes you need multiple. So there is no way of predicting that. And I'm saying this because I struggled with it initially. I wanted this perfect surgery. Sometimes you don't. Like now I have a patient who has Barrett's esophagus, right? But also has adrenal insufficiency. Which surgery am I going to give? Sleeve bypass. So that's when I said I chose to do a bypass on her. with the understanding that if she ends up with marginal ulcers or something, there's always an option to kind of go back and reverse that. Now, some people would choose sleep because how far does that Barrett's esophagus progress? So I like what you're saying. Like, yeah, put the J tube in, and if you're not going to use it, you can always go back and resect that or put it in continuity.
Yeah, I think we need to, I mean, just like we're getting obesity as a chronic, right? There's different spectrums of it. If we truly believe that, then surgery is in that algorithm somewhere, either the starting point or some point of the medications, right? It's just the continuity of care for these patients. And so I think the tendency, the first thing to do and is a gut reaction towards your patients is that you want to blame the patient for what's going on. It's like, oh, you didn't listen to us. You didn't, but you have to have a little bit of compassion. Or my surgery is perfect. Why? What do you mean you gained weight? You need to eat and diet and exercise. So it's you got to take the personal part out of it, and the blame and things. Of course, there's accountability for things, but really that's I think we have to not be so judgy.
100%. I mean, again, that comes to the weight stigma that we've been like, the more I read about it, the more we understand that it's sometimes prevalent in our own office. It's like when the patient starts gaining weight, you see your dietitians and everyone else starting to talk about this thing. Sometimes it's just a disease process.
Yeah.
I have one last question. Sorry.
Oh, wait. Before the question in the chat, can I ask
go ahead. I was going to ask that
hernia? When you had an internal hernia with the person with the remnant, not with the remnant, with the root limb that was tacked up, did you resect the root limb at that point after they had the internal hernia?
We did, yeah.
All right.
This was a potential lead point for that.
Yeah.
We weren't using the J tube anymore.
I was just curious.
Okay.
The other question we have is, endoscopic ultrasound guided large axial stents or the H procedure can give you the same results, so with less complications. Have you tried that?
So I don't have access to that in my community. People that do that. So I know there are endoscopic folks that do that. Potentially, and there are papers that talk about reversal endoscopically, for sure, for some folks. You still have, I guess it depends what you're doing, right? You still have that marginal ulcers.
That's right.
If you have this large axial stent, you're just creating a GG fistula. And so if you didn't have marginal ulcers, now you do.
Now you're getting one. I was going to say that. I think if you do an H procedure, that's why like I had a patient who needed the EUS and they wanted to do an H procedure, but I'm always skeptical about H procedures precisely for what you said. Now you have a GG fistula, and that's going to cause marginal ulcers. So you're not actually addressing the the concern that the patient has or the problem that the patient has. So.
And I don't honestly know how large of a stent you can place, but I can't imagine it's more than, that big of a, and so you're kind of going on the side to your remnant, right? And so you're trying to have food diverting that way. You're having some food maybe, but really still food is going down the same. So how much of a effect you're going to get if you're doing for malnutrition and such, I don't know necessarily.
I mean, the
So
easier
it depends on what your
option.
goal is.
The easier option would be just to put a G tube if you're doing it for malnutrition as opposed to an H procedure, because again the concern is marginal ulcers, right?
Yeah, I think when we say G tubes, like I don't know how it is in where your area is, but people they refuse. They're like, no way am I dealing with a G tube. Like they.
I think
it's
that's
like
Californian.
yeah.
In Pennsylvania, everyone's fine. They're like, give me a G tube. I can.
Oh man.
Yeah.
The pain, it hurts. I have to do like lidocaine patches. They're like, oh, I flush it. I can feel it. Like it's anyway. So it's very
Anyway.
Understandable. Some people do. So.
Right. But any other questions? Your last chance to ask Dr. Ma any questions?
I have one last question.
Okay, go ahead.
Do you think the root limb or the common limb, the ratio of the two plays a part in malnutrition for these patients? And we've seen like a large number of them have certain lengths that you like their patients likely get malnutrition for these things. And it's worthwhile to measure the common limb.
Yeah, there's been some studies that have talked about, sorry, I get the door here. Brew limb and how you could size it according to the total bowel length and percentages. There's definitely a lot of talk about that. And when we talk about distalization, like what is the appropriate length? We do know that from all studies that the safest part, and we don't know why some people get diarrhea, some people don't, and distalizations and things like that too. But we do know that you don't want to do a tall shorter than 400. So total elementary limb length. So your roux plus your common channel should be no shorter than 400. And your common channel should be no shorter than 250 as well. So that's one of the papers Namiri has published on this, talking about the limbs for small bowel. But in terms of the roux limb length versus the BP limb, so that's where your nutritional issues kind of come. What I've noticed actually more of the malnutrition patients, it's not the ones that kind of develop right away. It's years down. And I think our average age of patients that came through that needed the reversal of like 8 or 9 years out. And so something happens that triggers that malnutrition. They were doing great for a long time, and then something happened where that triggered that.
Great.
So anyway, but
All right, guys.
thank you.
Thank you. Thank you for joining us, Dr. Ma and Dr. Wei. This was really, really informative for all of us, and I'm sure our fellows appreciate that. So we'll see you guys around next for the next month. Our topic is going to be AI use in bariatric surgery, so stay tuned for that one. And I guess I'm going to say happy holidays from all of us.
Happy holidays.
Happy holidays. Thank you.
Bye.
Bye-bye.
Bye.